Dear viewers, it was my privilege today to be on this Instagram meeting with all of you, and you are all welcome to join us at Third Park Hospital, Aga Khan, opposite Aga Khan University Hospital. I am Dr. P.S. Patel, Praful S. Patel. I am a gynecologist and I am specializing in infertility. I'm also a senior lecturer in the Department of Obstetrics and Gynecology, Aga Khan University Hospital, Nairobi. I know all of you have so many burning questions about IVF, but let me just start off with infertility. IVF is just one of the treatment of infertility. And how do you define infertility? Infertility is inability to achieve the pregnancy after 1 to 2 years of trying unprotected sexual relations. Approximately all over the world, about 15 to 20 million couples are having difficulty in achieving the pregnancy. In short, I will put it this way, 1 in about 15 to 20 couples in their reproductive age, they are having difficulty in getting the pregnancy. So what are the causes of infertility? The causes of infertility we divide into 3 major categories. One is obviously the male factor infertility, whereby man's semen does not have enough number of live, motile, and morphologically normal sperms to fertilize woman's egg. The second major cause is anovulation. Anovulation means every month, either right or the left ovary in a woman is supposed to grow and release 1 egg every month. And because of some hormonal problems, endocrine disorders, the ovaries fail to grow or release the eggs. That obviously ends up with infertility. And the third cause is the tubal factor and the uterine factor. Tubal factor, you know that the fallopian tube is a transport for the woman it gets transported through the fallopian tube. 40 to 45% of the couples after infertility, the man is responsible. Everything is normal in a woman, but it's a male. Remaining approximately 55% of the women is usually either tubal factor, which is about 25 to 30% of the women, they have tubal factor. And the remaining one is the ovulation disorders. Those are hormone disorders. The male factor infertility, normally the man's semen should have approximately about 25 to 30 million sperms per ml. And when man ejaculates, he ejaculates normally 3 to 5 ml of semen every time he has sexual relations. Some men, they have less volume ejaculate and the semen does not contain enough sperms. You might be asking questions that every month when woman releases 1 egg, why we need millions of sperms? Because most of the sperms reach there. And unlike egg, woman's egg, the sperms are motile. They are supposed to move forward. And because of some chemical produced by the woman's egg, these sperms, they literally compete with each other. They get attracted towards the egg. But if the sperm count is low, if the sperms are not motile, then none of them reach the fallopian tube where the egg is waiting and the egg is not fertilized. So this is male factor infertility. Another cause of male factor infertility is that some men, they have paraplegia. That means they are paralyzed below the waist. And because of the paralysis, they do not have erection, they do not have ejaculation. And that is, again, obviously, the testicles are producing sperms, but the sperms are not coming out. So that could be the cause. The other cause in a man is that, yes, the testicles are producing sperm, but unfortunately, because of some reason, because of the infections, because of the trauma, because of the surgery on the scrotum, the vas deferens, which is supposed to transport the sperms, gets damaged, gets blocked. So these are the overall causes of male factor infertility. Now coming back to the female factor infertility, that is uterine and the tubal factor, and then the ovulation problems. Because of the sexually transmitted diseases, quite a few number of women, the fallopian tubes get damaged, they get blocked. And once the tubes are blocked, obviously the egg is not transported, the sperms are not transported, and they don't unite, and obviously the pregnancy doesn't result. Uterine factors. The uterine factors, the uterus, the womb is the house where the embryo grows. If the uterine environment is hostile, either the embryo doesn't get implanted or woman has got repeated miscarriages as well. And some of the uterine factors is like tumors, like fibroids, polyps. They don't allow the embryo to get implanted. The other causes are adenomyosis, endometriosis. The tubes are like a hollow rubber tube-like structure, which is not supposed to be blocked. And it is like a hand, and it is freely mobile in a woman's tummy. At the end of the fallopian tube, one side it opens in the uterus, the other end has a tentacles like octopus. So when the egg is about to come out from the woman's ovary, these tentacles, octopus-like tentacles, they go and grab the egg. Because of any reason, like infections, like endometriosis, like fibroids, the tube is not motile. It doesn't go and pick up the egg. And that's why, of course, the pregnancy doesn't result. So these are the causes, tubal factor in a woman. The other cause is the ovulation disorders. And the major cause of ovulation in the disorder is the end ovulation. And quite a few number of you know that some women, they have a condition called PCOS, PCOS in layman's language we call it, and that is called polycystic ovarian syndrome, whereby your ovaries, they grow the eggs, but the eggs don't reach the maturity. They die when they are about 8 to 10 millimeter, and the ovaries enlarge in size with small cysts, and that's why it is called polycystic ovaries, and the ovulation doesn't occur, obviously. The other endocrine disorders are like high prolactin level. The prolactin hormone is the hormone which is responsible for the lactation. When woman is pregnant or breastfeeding the baby, this normal hormone is normally high, but without pregnancy or breastfeeding, if it is high, It doesn't allow the ovaries to grow and release the egg. The third reason is the ovarian reserve. This is the difference between a man and a woman. Man's testicles, if they are producing sperm, on an average, they continue producing sperms unless the testicles are damaged because of the drug, disease, or the surgery. While woman is born with fixed number of eggs in her ovaries, and at the age of 11, 12, 13, when she starts her periods, these eggs, they start growing and they start coming out from the ovaries. So as the woman's age advances, the number of eggs continue going down. And one of the reasons in today's woman is the low ovarian reserve. And the reason is the woman postpones her childbearing function to later and later ages because of education, because of the financial stability, because she's not sure about the man, she haven't found Mr. Right. So she keeps on postponing the reproductive function at later and later ages. And as the age advances, the number of eggs and the quality of the eggs go down. And particularly after the age of 35, the decline in the ovarian reserve occurs quite fast. And particularly after the age of 40 years, it accelerates really. And that makes it difficult for a woman to become pregnant. Even with the treatment, it becomes difficult really. So now these are the reasons I have enumerated to you, viewers. You will be having questions, but at the end of the session, if I have not answered your questions, feel free to ask us questions. After the couple come to us, we start investigating them. Depending upon the number of months, the years they have tried, and then we establish the cause of infertility, whether it is a male factor infertility, tubal factor, or uterine factor, or ovulation disorders. And we try and correct one by one, and we decide what is the best method of treatment for this couple is. So, we normally, if the couple is young, if the couple have not tried enough, then what we normally do is that we give them ovulation induction drugs. Simple, we start with the tablets, and woman takes this medication for 5 days, starting from day 2 to day 6, and day 11 she comes to our office. We do internal ultrasound to find out whether the eggs have grown in her ovaries or not. And if the follicle is mature, which is more than 18 millimeter, then we give her the trigger shot. And after the trigger shot, the ovulation occurs, and now we give them the choice. Two alternatives. One is that they can try at home natural sexual relations, or obviously natural sexual relation, if the husband's sperm count, motility, morphology is normal, then they can try at home. But if the sperm count is slightly on the lower side, if the motility is lower, then we recommend them to do intrauterine insemination, IUI, whereby instead of trying at home, the husband comes to our office, he collects his semen, and we harvest maximum number of his motile, morphologically normal sperms, and we bypass the woman's vagina, the cervix, and put maximum number of husband's sperms in the uterine cavity. So that reduces the distance traveled by the sperm from the vagina to the fallopian tube, and that increases her chances of becoming pregnant. If this treatment doesn't work, then obviously we go a step beyond, and that is now IVF. What is IVF? IVF is a short form of in vitro fertility fertilization. In vitro means outside the body. In the laboratory, we fertilize woman's eggs and the husband's sperm in the laboratory, and we create the embryo. And after 3 to 5 days, we put the embryo back in her womb, and that is IVF. IVF is not a simple procedure. It is difficult procedure. It is quite taxing for a woman psychologically, because in IVF, what we do is that when woman starts her periods, on the second day of the period, she comes to our office, we do internal ultrasound and see the ovaries, how many eggs, how many antral follicles are there, and depending upon her age, depending upon her hormone levels, depending upon her past history, we decide the dose of hormone injections. And she continues taking these hormones every day. It's a very small little needle. It is very easy to put the needle on the tummy and inject every day. And then on day 6, she comes back again, and I do the ultrasound and find out how many follicles have started growing in the right ovary, in the left ovary, and what is the size of the follicles. And depending upon the number and the size of the follicles, now we decide the dose of the hormones. Then onwards, she keeps coming to our office every alternate days. That means 6 days, 8 days, 10 days. And then we continue monitoring the growth of the follicles in her ovaries. It takes approximately 11 to 12 days of injections to grow adequate size of the follicles in her ovaries. And when I say adequate size, means 18 millimeter plus. And once the follicles are mature, we plan to harvest those follicles. We admit her in the hospital, we take her to operation theater, and we put her to sleep. And from inside the vagina, under ultrasound guide with a needle, we harvest the eggs from the right ovary, left ovary. And next to the operation theater, we have a laboratory where our embryologist is sitting there. The embryologist is a specialist who creates the embryos. At the same time, the husband comes and gives us his sperms. In our laboratory, our embryologist, they harvest the eggs from the fluid which I have harvested from the woman's ovaries, and she isolates the eggs, she grades the eggs, and takes one egg of a woman. She selects one healthy, motile sperm or a husband, and she physically puts them together, and we allow them to get fertilized in the incubator, which acts like fallopian tube, whereby in the incubator 24/7, the temperature, the humidity, the oxygen concentration, the carbon dioxide concentration, they are all maintained continuously. And we check these embryos, that how many eggs are fertilized, how the embryos are growing. This is IVF, whereby we allow the sperm to go and fertilize the woman's eggs in the petri dish, in the laboratory. It is our experience that by doing simple IVF, sometimes 20 to 25% of the eggs don't get fertilized, and that's the wastage. So in that case, then we go step beyond, and that is ICSI. ICSI is the intracytoplasmic sperm injections. And we recommend ICSI, particularly for those couples who do not have enough number of eggs, whose husbands do not have enough number of sperms, a live, motile sperm, normal sperm, they do not have enough. So we can't rely on nature. Simply we mix them and we allow them to fertilize, and sometimes fertilization doesn't occur. And that's why ICSI is the ideal procedure for those kind of couples, whereby we physically fertilize each and every egg of a woman, and then monitor the growth of these eggs in the laboratory, in the incubator. After we have created the embryos, depending upon the number of embryos, quality of the embryos, and her previous treatment history, now we decide which day we should transfer the embryos in the woman's womb. If, let's take example, if the couple is young, if we have a good number of embryos, let's say more than 5 embryos in our laboratory, and the best quality embryos, then we give them the option of growing these embryos to day 5. What happens day 5? Those are called blastocysts. And I put it this way, explain you in layman's language. Here, we are taking the egg of a woman, we are taking the sperm of a husband, and we are fertilizing each and every egg. And sometimes, because of the abnormalities of the egg or the sperm, either some of the eggs don't fertilize, or if they fertilize, the embryo, they keep on dying on day 2, day 3, day 4, day 5. So those embryos who survive on day 5, they are called blastocysts, and on an average, they are the best embryos. Genetically, you might be having questions, how many embryos we transfer in the woman's womb? It depends whether it's a day 3 embryo or day 5 embryos. Depending upon the couple's age, depending upon the previous history of a couple, how many times she has tried. But let's take example, if there are day 3 embryos, then, and if woman has tried previously failed IVF cycles, then we select 3 healthy embryos and put back in the woman's womb. If they are day 5 embryos, then we take only 1 or 2 blastocysts and put in the woman's womb. Probably you might be having questions that why I don't transfer more than 3 embryos or 2 blastocysts. I'll go back again a little. We want all the couples to succeed through IVF. But remember one thing, if woman becomes pregnant with twins or triplets or quadruplets, the complication rate is so high. Like miscarriages, preterm labor, growth retardation for the babies, mental damage to the baby, and the mother also develops complication. Her chances of developing high blood pressure, preeclampsia, gestational diabetes, preterm deliveries are very, very high. And after delivery, she had got higher chance of even developing postpartum hemorrhage. So there is no point in making woman pregnant with twins or triplets or quadruplets when we know that she might miscarry or she might develop complications, and probably the newborn children might develop so many complications. So that is the reason why in our unit we have decided that if there are day 3 embryos, we select 2 or 3 healthiest embryos, or if there are day 5 blastocysts, we select 1 or 2 blastocysts only, and we transfer in the woman's womb. Now, embryo transfer is a simple procedure. It's an outpatient procedure, whereby we take you to our operation theater, we put your legs up, and without anesthesia, we put the speculum in the vagina and put the embryos back in your womb under ultrasound guide. And on an average, it is very well tolerated. Yes, it is little uncomfortable, but on an average, most of 99% of the women, they tolerate the procedure well. And once we have put the embryo back in your womb, we allow you to rest in the hospital for 10-15 minutes, and you walk out and go home and take it easy for a couple of days and then carry on with your normal routine activities. But obviously, we recommend you not to do the strenuous exercises like aerobic and high impact kind of exercises. And after 10 days to 2 weeks, we do your blood test to find out whether you're pregnant or not. So this is IVF ICSI procedures. And before that, there are so many other treatments which I have enumerated for you. I might have missed something. Let me go through. Yes, one of the questions my staff has written here, is there any other option to try after failed IVF procedure? Yes, as I had mentioned it to you, the successful pregnancy depends upon so many other factors. Take example of a woman's health. For example, if woman has got high blood pressure, she's quite obese, if she has severe diabetes, if she has some heart complications, then it is quite risky for her to carry the pregnancy. In that case, then yes, we create the embryos by doing IVF, by using her own eggs, her husband's sperms, and instead of transferring the embryos, we hire a surrogate mother and put the embryos in surrogate mother who carries the baby for them for 9 months. And after delivery, the genetic couple, biological couple, they take the baby home. Other scenario, the uterus, the womb, which is supposed to carry the baby for 9 months. Sometimes the womb is so much deformed because of the disease, like fibroids, like infection of the uterine cavity, and the uterus, the endometrium, where the embryos are supposed to grow, just doesn't grow. In that case, then we have to hire the surrogate mother and probably put the embryos in her womb. Or if woman had undergone hysterectomy previously because of any reason, like cancer, like fibroid, like endometriosis, like she had postpartum hemorrhage during previous delivery and the uterus was removed. In that case, then of course her ovaries are there, her eggs are there, so we create the embryos, put back in the surrogate mother who carries for 9 months. The third option, as I had mentioned it to you about the ovarian reserve, some of the women, they have very low ovarian reserve, or some of them, they undergo premature menopause. Her ovaries, they get exhausted prematurely at the age of 35 years of age or 38 years of age, 40 years of age, and they do not have eggs. In that case, then obviously we borrow the eggs from somebody else, from the donor. We fertilize with the husband's sperms and put back the embryos in the womb. On other side, the husband's sperms, for example, is azoospermic. Thus, testicles are not producing sperm at all. In that case, then obviously we borrow the donor sperm, fertilize with woman's sperm, eggs, and put back the embryos in her womb who carries. The time has come, the science has advanced so much that no woman should remain without a baby if she wants one. So, in nutshell, I have said quite a lot, and you might be having burning questions, or my staff here, if they have questions, they can ask the questions and I'll answer them. Thank you, viewers.
Thank you, Dr. Diaz. We really appreciate that. So what we need from you, we have a few questions that have been posted on our website. So I'm just going to ask you. What tests are essential to find the cause of infertility?
As I mentioned earlier on, when the couple come to our clinic, we do basic three tests. One, we do the husband semen analysis. Number two, we do the hormone test in a woman to find out what is the ovarian reserve, whether she is suffering from hyperprolactinemia or whether she has got polycystic ovarian syndrome. And number three, to find out how her ovaries are, how her womb is, and the fallopian tube. And there are two tests we do. One is the transvaginal sonography, internal ultrasound, which gives me fair idea about the muscles of the uterus, the lining of the uterus called endometrium, and the ovaries. If there are any cysts in the ovaries or not, like chocolate cyst of the ovary, polycystic ovaries, or other benign cysts. For fallopian tubes and the uterine cavity, we do X-ray called saline infusion sonography or HSG, which is fairly a simple, tolerable procedure whereby they put the cannula in the cervix, they inject the saline and do the ultrasound, and we can see the saline going in the uterine cavity and in the fallopian tube, or X-ray HSG whereby they put the dye in the uterine cavity. The uterine cavity is seen clearly. The fallopian tubes, this dye enters the fallopian tube and it spills out in the tummy, and we can see whether the tubes are blocked or not. So these are the basic tests we do on all couples. And depending upon the results of the test, we might have to do further tests, either more blood tests in a woman or detailed blood test or semen analysis on a husband, or going for laparoscopy or a hysteroscopy in a woman if we find some abnormality in the uterine cavity or the muscles of the uterus or the fallopian tubes, and we try and correct these factors.
Awesome. Thank you so much, Dr. K.S. So another viewer has asked two questions. I think they can be answered side by side. Number one, is IVF the first procedure to try while initiating infertility treatment? And what are the chances that a patient can conceive in their first cycle of IVF?
Right. So I did mention that IVF is not the first line of treatment. There are so many other things before IVF we can do. But in nutshell, I'll put it this way. One has to put all the causes of infertility in that particular couple and make the decision what is the best treatment for that couple. I'll just give you an example. A couple is 42 years of age. Her ovarian reserve is very low. Unfortunately, we don't have any other option but straight away to go for IVF rather than wasting time and money, because then the biological clock of a woman is ticking. More time I waste, more and more eggs are wasted. For example, couple is young, in their, let's say, mid-20s or late 20s. They have tried for 6 months, 1 year to have a baby. We find out what are the causes. Then I can afford to wait for 6 months, 1 year, 2 years, trying some other simpler way treatment for infertility. And quite a few number of them succeed. The success rates of IVF, we divide couples into two groups. Those couples where the wife's age is less than 35 years of age, and those couples whose wife's age is more than 35 years of age. So you can imagine I am stressing on the wife's age because the number of eggs, the quality of the eggs go down. And similarly, because of these reasons, even the success rates drops in IVF. So those couples who are young, the success rates of IVF is approximately about 40 to 50%. Those couples where wife's age is more than 35 years of age. When I say more than 35, I would say 36 years to 45 years of age. The success rate drops to 33%. So you can imagine the difference in the success rates. But every time we do the IVF, and obviously the success rates keep on, increasing. And one has to try not once, maybe twice, and sometimes 3 times also. But on an average, we don't recommend couple to undergo more than 3 times IVF. That will be a waste of their money and probably the time. In that case, then of course, we offer them alternative ways. And that is the donor egg sometimes. We might have to offer them. Yes.
Great. Thank you so much, Dr. K.S. That was very detailed. So there's another one. Are there any fertility boosting tips that you can share? And what fertility treatments and techniques are offered at Third Park Hospital?
All right. At Third Park Hospital is the state-of-the-art facility. We have started about 2 years ago. And our IVF center, I would say, is one of the best centers probably in this region, whereby our operation theater, our embryology laboratory, we have state-of-the-art, most modern equipments. However, we do all the treatments what is available in Western countries here as well, including semen analysis, semen preparation for IUI, semen preparation for IVF. Obviously, we do IVF and ICSI as well. We do hatching. We do TISA and SSR. TISA is the testicular sperm aspiration, and SSR is a surgical sperm removal, whereby when the man's vas deferens is damaged or blocked, semen does not have sperm. The testicles are producing sperm, but they are not coming out because the vas deferences are blocked. In that case, then surgically we remove the sperm from the man's testicle. We fertilize woman's eggs with his sperm. We create the embryos, put back in her womb. The other procedures we do, obviously, any cyst aspiration before IVF we do. We do fertility enhancement surgeries, minimal invasive surgery, that is hysteroscopy and the laparoscopy. We have 3D laparoscope in our theaters where the patient's safety is paramount, and that increases our success rates, one of the best in the region.
Thank you, Dr. Yes. So just to end the conversation, I just wanted to hit a little bit on the embryology aspect, which you can answer clinically. Does the quality of the egg or the sperm remain the same after cryopreservation?
All right. I forgot to mention, my apologies, but at Third Park Hospital, let me go a little backward now. We call it as a fertility preservation. As I had mentioned earlier on, because of various reasons, because of the education, because of the financial stability, because of all other socio-economical problems, woman postpones her childbearing function. But she wants a child, if not now, in future. In that case, then we offer them the fertility preservation, whereby we stimulate her ovaries, grow the eggs, harvest her eggs, and freeze them for future use. If not today, maybe tomorrow, day after tomorrow, when she finds Mr. Right, and if she wants a baby, we already have her eggs frozen, we thaw them, we fertilize with the sperm, create embryos, and put back in her womb. Or For example, nowadays, you know that quite a few number of people, they develop cancer of the various organs of our body at earlier and earlier age, and they need to undergo surgery, they need to undergo radiotherapy, chemotherapy. Not only women, men also, of course. So those people, man or a woman, who is undergoing cancer treatment, their fertility is damaged. So before they undergo this treatment for the cancer, we offer them fertility preservation. For a man, we freeze their sperm. For a woman, we freeze their eggs as well. Some men, for example, at the moment they feel that they have finished childbearing function, they want to undergo vasectomy, permanent method of family planning, and sometimes we do offer them to preserve their sperms, and they ejaculate, they give us, and we freeze their sperms in case in future if they decide to change their mind and have more children. Embryologist, my staff ask the questions. I'll put it this way: if the gynecologist is the brain of IVF, then embryologist is the heart of IVF. Come what may, how efficient I am to prepare the patients for IVF, but if my embryologist is not efficient, whatever hard work I do, it goes down the drain. The embryologist is the most important in our IVF lab, and she is in charge. I'm not in charge of the embryology lab. She is in charge, and she selects the eggs, she selects the embryos under microscope, and she fertilizes, creates the embryos for me, and I'm the one who do mechanical job of harvesting the eggs, putting back the embryos in the womb. So the embryology is the most important person, second most important person in IVF treatment, to be honest. I forgot to mention at Third Park Hospital, as I had mentioned earlier on, that we use only maximum 2 to 3 embryos if they are day 3, or 1 or 2 blastocysts if they are day 5. And some couples, they have surplus embryos left. And with their permission, if they want, we freeze these embryos and we store them in our facilities for 5 years. The advantages of this: suppose if the couple becomes pregnant after 1 year or 2 years, she wants another baby, she doesn't have to undergo all this treatment. We thaw them, we prepare her womb and put back in her womb. So the advantages are 2. One is that she doesn't have to undergo this treatment. The expense also is less, almost half only. And number 3, remember one thing: if your age is 35 years of age, today I harvest your eggs, create your embryos, and at the age of 40 years you come back, your egg quality will be so poor. But if I have your embryos frozen at the age of 35, your embryos will remain of today's age. The chances of that baby having chromosomal abnormalities are less than at the age of 40 years. So these are the advantages of freezing and storing your embryos or your eggs or the man's sperms. Other question my staff asked me is that once we freeze the embryos or the sperms or the eggs, when we thaw them, what happens to these eggs or sperms or the embryos? We use a unique technique called vitrification, whereby almost 90% of the either sperms or the eggs or the embryos, they remain in the same quality when we froze them. So that is the unique technique nowadays they use all over the world, and that is what we practice here at Third Park Hospital.
Dr. P.S., I want to add on to that. In your opinion, what is better for fertility preservation? Frozen eggs, not for fertility preservation, but for, say, a person coming for a donor. Frozen eggs or fresh eggs? What would you suggest for a patient who needs donor eggs?
All right. So the question my staff ask is that, for example, if couple comes who want a donor eggs, for example, then I have to synchronize the donor's periods and the recipient periods. And sometimes it's not possible to synchronize their cycle. In that case, then we harvest the eggs from the donor, fertilize with the husband's sperm, create the embryos, and we freeze the embryos while waiting for the recipient to get her periods. And it doesn't make much difference really, or any difference, for example, for a donor eggs or the embryos, whether I use the fresh embryos or frozen embryos to the recipient. Success rate doesn't make any difference. Going back again, the same question, I'll put it this way, for a couple who is undergoing IVF, shall we consider fresh embryo transfer or frozen embryo transfer? Remember one thing, here we are stimulating woman's ovaries. We are manipulating her hormones. And because of the high level of hormones during IVF, sometimes the lining of the uterus, called endometrium, goes out of the phase. This is nature's fantastic mechanism, really. In nature, what happens? The embryos are created in the fallopian tube, and this embryo continues developing and getting transported in the fallopian tube, and it comes in the uterus where the endometrium is growing. So when the embryo comes to the uterine cavity, the endometrium is mature. We try and mimic this nature, but sometimes it is impossible to do that. And when we feel that the woman's ovaries had hyperreacted, when we feel that the lining of the uterus, the endometrium, is out of phase, then it would be a waste of a woman's eggs and the money if we transfer the embryos. So we freeze the embryos, and after a month or two, we use those embryos as a frozen thaw embryo transfer, whereby we shut down her ovaries not to produce the egg or the hormones. We give her some medicine to grow the lining of the uterus, and we monitor the growth of the endometrium. And once the endometrium has matured, we transfer the frozen embryos. In that case, then the frozen thaw embryo transfer has a better success rate than the fresh embryo transfer. But one has to individualize this depending upon the couple and her response, really. I hope that has answered your question.
That's fantastic. I think we have finished there. We've done very well. I just want you to say thank you to the audience, and then we can close it.
Right. So, audience, if you have any burning question, you're welcome. Otherwise, thank you very much for participating in this.
Please contact the clinic. They can contact the...
All right. So if you have any question or queries, you can always contact us at Third Park Hospital, and my office is in the Doctors Plaza, Aga Khan University Hospital, room number 114. But you can always reach me through Third Park Hospital as well.
Great. Thank you so
Once
much.
again, thank you very much, viewers.
Thank you. Take care.
Thanks. And good night.